This week on the Inside Athletic Training Podcast, we're joined by Dr. Matt Ithurburn, the Director of Clinical Research at the American Sports Medicine Institute in Birmingham, Alabama. Dr. Ithurburn leads ASMI's clinical research team, working alongside Andrews Sports Medicine and Orthopaedic Center, and we're excited to dive into his research and what it means for athletic trainers working in baseball today. Enjoy the show. All right, Matt, welcome to the Inside Athletic Training Podcast. Super excited to have you on to talk all things research, ASMI, and your career as well. We'll get into all those details about that good stuff shortly. But for the listeners who aren't familiar with you and your career, I'd love to give you a minute to share some information about your background, where are you from, how you got into sports and physical therapy and everything that got you going in this profession.
Yeah, for sure. Thanks for having me, Sam. Matt Ithurburn. I'm currently the Director of Clinical Research at ASMI, the American Sports Medicine Institute. I'll share a little bit about kind of my path and career. So started off in clinical training as a PT. Had a sports and athletic background, played multiple sports. And I think the merging of kind of data science, patient care, and, kind of sport adjacent was appealing. I always had an interest in going into sports medicine rehab, at least as a PT student, and always had, I think, interest in research and data, at least kind of evidence-based like care and practice, and had a unique opportunity. After my DPT traiing, I was at Ohio State Sports Medicine. I was doing a PT clinical residency while there, and actually met who ended up being my PhD and dissertation advisor at Ohio State. So she was also had a clinical background as a PT. We're working in the same sports medicine rehab clinic. She was kind of doing some evenings there, more focused in sports medicine, kind of rehab research, mostly lower extremity injury. Her name's Laura Schmidt. And so, I just had a really kind of serendipitous timing to kind of shift focus from full-time clinical practice and to focus on research and do a PhD at Ohio State. So I was there until 2017. Most of Laura's work and thus my dissertation research, again, was in kind of knee and hip injury rehab, optimizing rehab, looking at kind of midterm rehab related outcomes, return to sport. And we had kind of some forays into looking at, the kind of early to midterm effects of lower extremity joint injuries on joint health, specifically like cartilage health and early cartilage degeneration. And we did some kind of cool stuff with MRI, looking at that. From there, I kind of anticipated being in an academic setting, likely for the rest of my career. I took an academic research faculty position at University of Alabama at Birmingham, UAB here in Birmingham. And I was there for about 4.5 years, and it was a great experience. I got to work with a lot of great people, and kind of continued this interest in research in lower extremity rehab. We did early on start to do some work using kind of wearable devices and sensors as kind of a next step for evaluating lower extremity injury, like surgical outcomes and rehab outcomes. So, accelerometers and other devices to measure kind of what we kind of thought of as like real world outcomes. And so that was kind of my first step into some of these, wearable, I would say kind of adjacent to sports science data. Right. And as a part of some of that research, we were just being in Birmingham, it was a no-brainer to try to partner with Andrews Sports Medicine in terms of recruiting some patients for these studies, knee and hip injury, kind of, young, athlete cohorts from them. And, they just see the most of these types of patients in our region. And so, was working with several of the clinicians and surgeons at Andrews on some of these studies, collaboratively recruiting patients and so forth. And had this opportunity come about at ASMI. There was interest in growing ASMI's clinical research and impact. Dr. Glenn Fleissig has been here at ASMI for most of his career, since the early 90s, and is, internationally known for work in biomechanics related to, mostly upper extremity injury and performance enhancement, injury prevention, technique and coaching and so forth, kind of, myriad of applications there. But there was kind of some interest in growing and expanding the clinical research at ASMI. And so that's kind of where that opportunity came about. I've been at ASMI since the fall of 2021, so almost 5 years. And it was, really a natural fit for me. I would say both having a clinical background as a PT and having most of my research training and outcomes research, it was a pretty natural fit for me to step into this role. Most of our ASMI clinical research is, I would say like broadly, like the broad category would be outcomes research. And that spans the spectrum, but, from non-operative treatments to surgical outcomes to, rehab focused assessments and outcomes, as well as just like big data registries, kind of big data is a big term right now. And that is a big focus of what we do too. So we have an ongoing surgical outcomes registry that we partner with Andrews on, and that is, shoulder to toes, really. Really all of those surgical cases and procedures we enroll into this outcomes registry. Of course, there's injury and, body region specific data that information that we collect from these patients. But it really gives us a lot of data to leverage in our research and to, apply toward very specific, treatments and injuries. The cool thing about working with Andrews is they are both a high volume kind of regional and nationally known sports medicine practice, but they also are really pushing the envelope in terms of like innovative assessments and techniques and procedures. So we might do a study that has, hundreds and thousands of patients in it, ACL reconstruction outcomes or something. And then on the flip side, we might have a really unique and small cohort of patients that, maybe nowhere else in the country or in the world is doing this procedure or, seeing this, type of patient cohort, or doing this type of technique or treatment or something. And so, it makes the job really fun and really cool. I get to work with a lot of really smart people, not just my ASMI team, but we, the ASMI fellowship programs, we have the largest alumni base of sports medicine orthopedic surgeon, fellowship trained surgeons in the world. We have 6 new ones that start with us every year. We also have a primary care sports medicine fellowship. So all 10 of those fellows, to some degree, we support their research while they're here. So we get to work with them. We have a gap year research internship for like pre-meds or pre-health students. We have 3 to 4 interns every year that are with us for a full year. So I think the coolest part of the job is just getting to work with a bunch of really smart people, and being able to do something a little different every day. Like, sometimes it's, analyzing data. Sometimes it's like, working with the team. Sometimes it's actually working and, with patients or research participants, and everything in between, as it relates to research. So, long answer to your question, but that's kind of how I got from, high school athlete to PT to research training to now being in a kind of full-time, like, sports medicine, research leadership role.
No, that's awesome. And really share some great detail about all the things that you guys do at ASMI. And one thing I'm curious from your perspective, just in your thoughts about your career and the arc it's taken. You mentioned, physical therapy at Ohio State, maybe having your hands on athletes and patients, to academic roles that you thought you might be in for the remainder of your career. Obviously didn't happen because of this opportunity. Are there things you miss about those other areas? Maybe it's like being in the training room or PT and working with athletes. just putting your hands on athletes and solving problems that way. Do you miss things like that compared to kind of what you're doing in an office? And obviously you have some exposure to that, as you mentioned, but what do you kind of miss about the old days of what you were doing?
Yeah, it's a great question, Sam. I definitely miss things about both my kind of full-time clinical role,
Hmm.
being a full-time like sports medicine clinician, and then being a full-time faculty member. There are things that I miss about both of those. Yeah, I mean, you kind of already hit the nail on the head. I think it's being able to solve real-time problems and
Right.
troubleshoot with athletes. And it's very easy as a clinical researcher to um, focus just on the data. I mean,
Hmm.
that's what drives what we do. But I
Yeah.
mean, as you know, like that only goes so far when you're working with an athlete in real time. And whatever the data might say or show, this isn't to say that it doesn't matter, but if it's not the right fit for that athlete or that patient in that moment, it's not relevant. And so you have to be able to, I think on your feet and try different things and assess like response and and iterate your approach with them in real time. I think that level of thinking is it's challenging and it's really rewarding. And that was, I mean, that's what I miss the most about clinical practice.
Yeah.
And I think it's the stakes are just so much higher when you're talking about, especially like collegiate and up athletes.
Hmm.
There's a lot on the line there. And I think that's really exciting too, to be able to make a
Right.
positive impact and build rapport and see those athletes, get back to, as we're talking about injury, like get back to where they were is really, really cool. So, I mean, that's probably what I miss the most on the clinical side. Like we get a little of that in some of the research that we do.
Hmm.
Honestly, probably even less than like our biomechanics team does, because they're really doing like physical biomechanical assessments with a lot of throwers and pitchers and
Yeah.
studies where they're having patients come in. I mean, a lot of the research that we do, we don't see any of these patients. For a few studies,
Sure.
we might do some evaluations or assessments
Hmm.
of kind of physical exam outcomes, or using some wearables and technology and stuff. But yeah, I mean, vast majority we're collecting data,
Yeah.
kind of outcomes data. So miss that. I think on the, from the academic job, I still kind of have my toe in the water in the academic world. Like still have a PhD student from UAB that is training with us at ASMI.
Hmm.
Her dissertation research is in partnership with a couple of surgeons at Andrews Sports Medicine, rotator cuff repair related stuff. And so, I still have that piece, but yeah, I mean, I do miss like teaching and interacting with students,
Yeah.
both clinical students and graduate students. I think that's it's a really rewarding thing to do, to see, these trainees that are really passionate and, kind of right on that like cusp of figuring out where their career is going to go. And there's just so many options,
Right.
like being able to mentor and teach students at that level is really fun.
Hmm.
Again, similarly, like I get a bit of it here with our interns and medical students that rotate with us and the fellows and stuff. But I'd say those are probably some of the things that I miss the most.
Yeah, no, it totally makes sense. I mean, a lot of our athletic trainers within PBATs or people who've gone on to do other things, the team atmosphere and being part of something bigger than yourself and working towards a goal like winning is just unbeatable, I think, for a lot of people who have done what you guys
For
do. So
sure.
it's cool to hear you echo that same statement.
Yeah.
Well, Matt, for the listeners who you gave a lot of great information about ASMI in general and what you guys do, but set the scene for us for, a week in the life of you. I know you're doing so much, whether it's managing outcomes data or projects offsite or externally funded studies, or there's so much going on there. Workshops that we
Yeah.
talked about offline, Andrew's baseball injuries course. Like there's so much going on there. It's
Yeah.
hard for someone outside of it to just understand the scope of what you
Yeah.
guys are doing every day.
Yeah.
Obviously, we hear about Dr. Andrews and what a legend he is and the connections there. But walk us through like a week for you, and I know it's going to vary. There's no normal in sports and sports
Yeah.
medicine and research, but try and give us an idea of like what's going on over there.
Yeah, that's a great question. I think what I love about my job so much is that no day or week are the same, and sometimes they look way different. But yeah, I mean, honestly, in my role now, I'm not doing a whole lot of data collection. Like as a PhD student, it was like all data collection and testing and research participants and, quality control of data, like in the weeds. We have an amazing team that really does a lot of that work for us in terms of the ongoing research and studies that we have. Like we probably have, I don't know, probably 15 active studies right now, but like some of those are like thousands of patient databases, like, ACL reconstruction outcomes, to we're doing a project in throwers with Lacertus syndrome, like Lacertus, nerve impingement, median nerve impingement syndrome, which sometimes gets like, it's kind of it's a tricky, like clinical problem in terms of diagnosing it. And it's kind of a diagnosis of exclusion that you'll see in throwers sometimes. And so we're kind of looking at what the clinical presentation clusters of that syndrome are. And, sometimes they'll go on to have surgical releases of that. And how do they do nerve symptoms and pain and return to sport and so forth. But I mean, that's like, I don't know, 40, 50 patients that have had that procedure here. I'm saying this just to kind of paint the picture of, the design of our studies, or what each of these studies look like, is very, very different. And so sometimes that involves like going over, and if one of our, let's say like one of our surgical fellows is kind of involved in one of these studies for their fellow research, it might be going over there and meeting with them, with, some of our team, like our interns or whomever, to be like, hey, where do you think we're going to find these data? And, or like, what matters for this injury or for this procedure? Like are there imaging data that we need to collect from the MRI? Is there stuff that we need to evaluate on here that, maybe that we need a clinician, like one of these fellows to do, because it's beyond the skill or, kind of training level of our interns or our team or staff. So yeah, I mean, really, my job is more like training, admin, and then a lot of like data analysis and writing. I would say that's the vast majority of my job. It's writing, grant proposals. It's editing or writing, papers or manuscripts from our research findings. Leading our team, kind of decision making related to like prioritizing. Kind of where everyone's efforts are and bandwidth, and how we prioritize our studies, partnering with the Andrew surgeons on developing new research ideas, how we're going to execute those studies, mentoring our trainees as they're trying to write abstracts and papers and things like that. Like I said, I have a PhD student here. And so just kind of, providing oversight for her research study, even though she's really leading like recruitment and testing and stuff for those patients, just kind of being a sounding board for her. So it's really more stuff like that. So I would say every day is different. I would say every day involves writing, to some extent, or like, analyzing or looking at data. As an outcomes researcher, I think that's really kind of my strength is trying to take a lot of data and make decisions as far as how do we reduce these data to, in some form that is clinically relevant, makes sense, and has an impact. And so I would say that's really a big part of like what my week to week. I would say, our team, it varies. Like, a lot of data that we collect for these studies are electronic health record data. So they, our interns might be doing chart reviews, collecting whatever this person had, a cartilage injury in this location in, their, whatever their medial condyle, or, this kind of meniscus tear, or, whatever, this kind of labral tear in their shoulder. Or, calling patients, collecting patient reported outcomes, doing patient interviews, managing big databases and data sets. So it's a little bit of all that stuff.
There's
so every study is a little different. So I would say that's maybe a peek into into the week to week.
The busy week to week you have going on there. No, that's great to kind of take an inside look at just how much you guys have going on. And that gets me to the next question. You mentioned managing the whole process is what you're in charge of, I guess in a super basic form, leading the team there. So when you guys say there's 15 studies currently ongoing, or even like there's new things you want to look at in a broad scale, how do you personally prioritize what's most important, what research is going to be most impactful, whether it's like a certain sport or a certain outcome, or how do you guys focus on like what's next, or building like the framework for once these 15 studies, once you're done, what are we doing next? Like, how do you keep that pipeline going with like what's most important in research?
Yeah, for sure. So, I mean, I would say from a big picture planning perspective and kind of design of studies and where the gaps in the literature are and where we can leverage some of the unique, either patient cohorts that we have here or patient volume that we have here. It's really done in close collaboration with our clinical collaborators at Andrews. Not all of our research is kind of just patients at Andrews, but I mean, probably 90% of it is.
Sure.
And so we work really closely with those attending physicians and surgeons, Dr. Kane, Dugas, Emblem, a couple of their newer surgeons partners there, Dr. Rothermick and Dr. Ryan, and then also with our primary care sports medicine non-operative physicians and fellowship attendings, Dr. Kohlberg, Dr. Ortega are kind of the two that we work with the most closely. So usually it's just like sometimes these conversations come about naturally as we finish studies. Our fellows present their research at the end of every year. And oftentimes, just as a result of those presentations or subsequent conversations, one of them might be like, "Hey, I was at this meeting, and I heard somebody talking about this procedure or this injury. What might it look like to look at that in our in our registries or in our patients, or it might be, hey, we're starting to do this new technique or this new approach, and we want to track and see how these athletes do in comparison with kind of some previous, technique or approach that we've used. Sometimes it's obvious. Sometimes it requires that clinical expertise and insight that these guys have, that even as a clinician and a researcher, I don't have, particularly when we're talking about like specific surgical, kind of, techniques or studies. And then, I think the second piece is really just managing personnel, and trying to figure out, who do we have working on what, and right. For which studies do we think we need to kind of, it's really important to kind of get those data out, as soon as we can, right. Versus others where, the dividends are going to, kind of research dividends are going to go on for years. So, like a big, multiple thousand ACL reconstruction outcomes database, like we're going to have the opportunity to ask some really cool and unique clinical questions out of that data set for a long time. Whereas, for example, we just published a paper that was looking at using UCL repair with internal brace as a revision procedure for failed Tommy Johns in collegiate and professional pitchers. And that's one where, it's a small cohort, but we wanted to publish that kind of as soon as we could. I think it was just published in Orthopaedic Journal of Sports Medicine in the last maybe 2 months. And we wanted to publish that because for a long time, we've known that, UCL reconstruction or Tommy John procedures as a revision for a failed one, the outcomes are pretty poor. And I think as some of these pioneers have developed this repair with internal brace procedure, I think they always saw it as a really good fit for being a revision procedure after a failed Tommy John.
Sure.
Tommy John procedures are still the gold standard, particularly for more severe injuries like full thickness UCL tears and distal tears and so forth. Applied in the right athlete, UCL repair with internal brace as a primary procedure is good, and we published some data on that about a year ago that compared repairs with reconstructions. But again, I think patient, and Jeff Dugas would echo this, like patient selection is really key in that,
right,
making decisions about those procedures. But that's just kind of an example of like a small little pilot study. I think there were 11 or 12 pitchers in that cohort, but all 12 of them, so they had a Tommy John procedure, and then they had a UCL repair with internal brace as a revision after a failed Tommy John, like either they developed symptoms or their graft tore or whatever. And all 12 of them got back to their pre-injury level. And I think probably 2/3 of them were professional pitchers. And, those data are pretty compelling. Yeah. Granted, it's a small sample. The follow-up was fairly short. I think it was, like maybe minimum was a year, and max was like 2. So, durability and stuff, I think still remains to be seen. And, I know Dr. Dugas would echo that comment too. So yeah, again, very, very long-winded answer to your question about how do you prioritize like research and studies, but I think it varies. Sometimes there's some external constraints, like
sure.
For example, if we have an upcoming podium at AOSSM, and for that meeting to present a podium, you have to have your paper already submitted to the journal ahead of time. So like gotcha. There's a hard deadline on a project that we need to finish and write a paper for. And then other times it's kind of where are the gaps in the literature. Maybe there's some urgency to get these data out and published, so we can build upon that work, or other researchers or clinicians can, kind of design, subsequent studies or integrate that into clinical practice. So yeah, it's not an exact science, even being a scientist. It is a bit of an art to kind of figure out, where do we allocate our effort and how do we do that? So
yeah, that's great insight there. And want to stick on the UCL topic just because, as I mentioned to you offline, we just published a podcast last week, episode of our research rundown show with Dr. Freehill from the Athletics, Dr. Cohen from the Phillies, Brian Shulman of the Athletics, their sports medicine director, Paul Bukite, head athletic trainer with the Phillies, and Joe Roush, assistant athletic trainer with the Phillies, talking about just like a Tommy John roundtable, essentially. What are they seeing? What do they think? Talked about like grip pressure and grip studies versus even the different balls used in Japan versus the collegiate level versus sticky stuff on the fingers, just everything that they could think of that was having an impact. And it was super interesting on the athletic trainer side. I want to kind of give you the floor to talk a bit about like your thoughts on, baseball released their pitcher injuries report a couple years ago with interviewing athletic trainers and coaches and getting like anecdotal evidence and things like that. It's such a hot topic, and there are gaps in the research, which I love that you mentioned. Kind of that's what drives you guys. What are your thoughts on kind of the epidemic in UCL issues? Is it youth sports? Is it pitching labs? Like, what are your overall general thoughts on that?
Yeah. So I'll preface this response by saying I would not categorize myself as an expert in UCL or elbow injuries.
Sure.
I would say that I, and even we at ASMI in our clinical research team, like we kind of look at the broad spectrum of sports injury and try to use outcomes data to answer those questions. So I wouldn't say that I, unlike Dr. Dugas or even Dr. Fleissig, who I would say are probably definitely more experts in that field related to the clinical treatment or assessment or prevention of elbow injuries than I am. But I'll at least do my best to answer this question and talk from a little bit of our data and the studies that we've published. I think first and foremost, what is, and you will know this, and I think everyone knows this, the measures that predict performance right now, particularly in pitchers, are the same risk factors for injury. And that's a big problem. When velocity and spin rate are kind of like the two biggest predictors of like what pitchers ascend, achieve, whatever they move up in, from high school to college to professionals, or they're the ones that, have whatever the highest like whip or BIP or whatever. everybody chases that. But the problem is those same things are what are linked with injury. And so I think first and foremost, finding ways to evaluate, if we're talking about pitchers in particular, pitcher performance with measures that are correlated with performance, but that decrease or at least don't increase injury risk is critical. And I think we still have to figure out what that is. I mean, clearly, like, throwing harder makes you a better pitcher. I mean, it's hard to get around that right now.
Right.
But like, I know that, like, everybody talks about, like, let's use like Greg Maddux as the example. Like, the guy didn't throw that hard, but his command was awesome.
Mm-hmm.
And so how do we, I'm not saying like that needs to be the new performance kind of target, but are there other ways that we can evaluate high performers in the sport, or identify those that are going to perform well, or things to kind of, aim for with regard to performance that don't also place those same athletes at higher injury risk? And I think that's a really uniquely baseball problem, and really uniquely like pitching problem compared to other sports. A lot of the sports that we see, or injuries that we see in other sports, are either like overuse or they're kind of one-time traumatic injuries. And I mean, okay, maybe there's some like systemic changes that you could make to whatever surface type, or make, injury or workload, or some of those things. But baseball and pitching in particular being such a metric driven sport, I think we're in kind of a weird, kind of paradoxical cycle with those measures. And so that's what I'd say to preface it. Now, I don't have the answers to what those are, but my gut says, though, with how, and again, not to be too cliche, like beating the like AI machine learning drum, but I think like we're going to get, in the next few years, like, we're going to get better and better insights into maybe finding performance related metrics that predict who does well, but also who doesn't get hurt, or, but I don't know exactly what that's going to look like. So that's the first piece. On our side, a couple of the areas that we've really been focusing on, I kind of already mentioned it, but Dr. Dugas in particular, as well as Dr. Kane and Emblem, have kind of pioneered this UCL repair with internal brace procedure. And as I said before, I think in those athletes that do unfortunately have these injuries, a really critical piece of that is selecting the right treatment for the right athlete, or the right patient or pitcher. Severity of injury, location, level, demands of the sport.
Right.
Have they had prior injuries or procedures? We early 2025, published a study in the American Journal of Sports Medicine that looked at and compared outcomes between baseball athletes that had either a UCL reconstruction or repair with internal brace. Most of them were pitchers. I mean, vast majority were. But a big sample, I think we had 250 plus UCL repairs, over 150 Tommy John procedures. Some really important highlights from that study were the injury subtypes were different between the groups. And this really speaks to like patient selection and indication for these treatment approaches. The ones with UCL repairs, predominantly partial tears, predominantly like proximal injuries, and for the most part, lower levels of competition as a primary approach and procedure, high school to college. Whereas I would say that there was probably a higher proportion of collegiate pitchers that had Tommy John procedures. They did not differ in outcomes across the board. So this was, at least 2 years after their procedure. Neither group had a higher proportion that went on to have a subsequent elbow injury or subsequent elbow surgery. They returned to sport at very high rates, in particular those that attempted to get back to the level they were at before. So, we really collect a lot of contextual return to sport data when we do these studies. So not just did you get back or not, or did you get back to where you were or not, but why, return to performance data, timing of return to sport. There are some challenges with collecting those data from athletes years after the fact. There are some biases, and we have to kind of deal with recall, and sometimes people can't remember why. I did go back to competition, but I can't remember the exact day, and then I went back to practice. We have to deal with some of that, and we recognize those limitations in this type of research. But at least as it relates to kind of their perceived elbow related functions, symptoms, and so forth, their ability to return to pre-injury sport, Tommy John procedures and UCL repairs they looked essentially exactly the same. Knowing that, again, injury severity differed between the groups, and there were some kind of clinical indications for each procedure. But what we found, though, was that the return to sport time, both return to practice and return to competition, was quite a bit shorter in the repair group. Less invasive procedure. Obviously you have kind of anchoring the graft and so forth versus the repair. Rehab differed a bit between the groups. And so that was kind of a key, some key takeaways from that paper. Yeah. And Dr. Dugas and Dr. Kane will say it over and over again, which is that we're not saying that one is better than the other. And it isn't even necessarily better that return to sport time, is faster for repairs, because the athlete needs to be indicated for that procedure. They're different procedures for different injuries. And yeah, they're all UCL injuries. But I think that's a really important takeaway from that paper. And then again, I mentioned the UCL repair revision paper. So that was just published in the last maybe month and a half or so. The last kind of piece that I'll talk about that I think is probably maybe a bit insightful to your athletic training audience is we have been doing a series of studies looking at the use of stress ultrasound assessment of the elbow as either, kind of a quick and less invasive procedure for evaluating elbow injuries than MRI, and also looking at adaptation in throwers and what does the medial elbow joint laxity, ligament integrity and so forth look like in non-throwers? What does it look like in baseball athletes without a history of injury and no symptoms? What does it look like in those with suspected medial elbow injury or suspected UCL injury? And we've kind of done this series of studies, both prospective, real-time, like going in and testing athletes, or using electronic health record data from our primary clinical partner, Dr. Kohlberg, who kind of has pioneered a lot of these assessments. And I think a key takeaway, one cool thing that we found, and Dr. Kohlberg has presented this a good bit, which is the kind of traditional approach of like applying a valgus load on the elbow and assessing like the joint space, and then determining, what is the joint space at rest? When you apply a valgus load, what is the joint space? What he has found in his clinical practice, and our data have borne this out, is gravity applies the position that they test kind of in the abduction, external rotation position off the table of the elbow. Gravity provides this kind of pre-valgus load on the elbow that doesn't get accommodated for. And what he had started to see was that, they were getting a lot of false negatives looking at kind of a rest assessment to a valgus load assessment. And so what he started to do, and I think we have some really kind of compelling data that we're trying to publish now in those with suspected medial elbow injuries, is what he is doing is first applying a varus load, taking the joint space, assessing it at rest, and then assessing it with a valgus load, and using that varus to valgus gap, like the amount of, kind of difference in joint space between those conditions, as the assessment of the elbow laxity, medial elbow laxity, as opposed to just rest to valgus. And, there are some kind of published thresholds for this amount of elbow laxity is kind of what's indicative of, a potential UCL injury, just to varying degrees, sprain grade 1 to partial tear to full tear. And so we have a study where we looked at and we're publishing this now, all baseball athletes with suspected UCL or at least medial elbow injury or symptoms. Not all of them had UCL injury or tear, that underwent both this stress ultrasound procedure as well as an MRI. And what we found was actually, we kind of compared the traditional, like evaluated at rest and then apply a valgus load versus this varus to valgus joint space gap. And in those with MRI identified UCL injuries, either grade 1 and up or grade 2 and up, that varus to valgus assessment was much, much more likely to identify people that met this diagnostic threshold for the ultrasound than the rest to valgus. So that's kind of one in the UCL space. It's not obviously a treatment outcome study, but kind of a cool diagnostic assessment study and series of studies that we've started to do. And we found similar things in the healthy baseball athletes too, that, we were able to appreciate more what we kind of think of as like acquired throwing related laxity in the elbow, even in those without a tear or without symptoms or injury, using this varus to valgus loading assessment technique compared to rest to valgus. So we're kind of seeing similar trends in those studies. The cool thing about ultrasound, obviously, is it's portable. You don't have contraindications like you do with MRI. It's way cheaper. You can do it in the clinic. You can do it on the field, particularly if you have someone that's trained in doing some of these assessment techniques. And I think that might be something that's, maybe both clinically relevant and kind of accessible to, the training room and athletic trainers as kind of a first line assessment. If somebody starts to develop some symptoms and so we're hoping to get that paper published here in the next couple of months.
No, that's awesome insight in so many different avenues of what's going on with UCL injuries in baseball. And I mean, it's crazy to think, like, let's see, 1974 was the first Tommy John procedure. We're still here talking about how you can improve what's not working, what works great, still having these injuries, still talking about like, hey, if you perform really well, this is an outcome that could happen. It's just wild to think about the timeline for that procedure and how, I mean, it saves so many careers, and then there's issues. And so that's awesome insight from you on a number of different topics within that broader topic of arm care. You talked about, gathering the data and how you guys do that. I want to kind of shift to, like, the professional sports leagues sit on enormous amounts of injury data, outcomes, biomechanics, like when we had Dr. Fleissig talking about Hawkeye. I know that there's so much out there that you guys are working with. I'm interested to hear more about your relationship at ASMI as like an independent research institution with professional sports leagues. For people that don't know, like, how it works, do they bring you in for research? Do they come to you for data? I know you have MLB workshops. Talk about your relationships with baseball, I guess, but also all professional sports leagues and how that works.
Yeah. So I'll start with maybe collegiate sports, and then I'll talk a little bit about Major League Baseball and professional sports. Really, the majority of the work that we do with professional sports is MLB. Collegiate sports, several of our Andrews Sports Medicine attendings and surgeons are team docs for some of these athletics departments, University of Alabama, Tuscaloosa, Auburn, among others, Troy. So we have kind of some natural partnerships there. There's still a lot. I mean, you can probably anticipate this, but I mean, there are a lot of logistical and regulatory hurdles to partner with academic institutions when you aren't affiliated with them, particularly in athletics. So just like in medical care, we have to deal with, and it's good, patient privacy and HIPAA. Similarly for patient or student athletes, patients, there are kind of similar guidelines with regard to, like, university related and academic or athletics related data. And so we have to navigate some of those hurdles. So the point is, it is a bit of a challenge to do some of these like true kind of athletics, sports medicine, collaborative studies, but we are fortunate to have been able to do this. So, example of one, we are doing a project with, and this is what's going to be presented at AOSSM this summer. Mm-hmm. We're doing a collaborative project with University of Alabama Athletics, looking at high ankle sprains in football athletes.
Okay.
And looking at some different treatment approaches, so depending on severity of injury and timing of return to sport and so forth, some of these, it's notorious that high ankle sprains are kind of a tough clinical entity to manage. I'm sure you've seen some in your career. And they're pretty common in football, especially right. in linemen and so forth.
Yeah.
Rehab can be slow, kind of the injury mechanism is essentially what you do when you walk, by kind of forced dorsiflexion. And so they've always been a challenging clinical entity to treat. And so we, in this project, these are all kind of, former or current, Alabama football athletes. There's been kind of an innovative surgical procedure that's been developed to treat these, where these athletes, especially with the more severe ones, are able to get back really quickly, like within weeks. And this is called a tightrope procedure. There have been some pretty notable football athletes at a high level that have had this procedure, let's say like toward the end of the season, getting back to like college football playoffs or national championship or NFL playoffs and so forth. Mm-hmm. And so we partnered with Alabama to not only leverage, because all of them were treated here at Andrews, not only leverage kind of our medical and patient reported outcomes data, but they also collect catapult GPS monitoring data in all of these athletes. And so it was kind of one of our first forays into using like real world performance, data, workload and kind of intensity related performance measures, as well as kind of typical clinically focused like outcomes data.
Right.
And so what was cool about that is, for all of these athletes, they have their baseline profiles of their GPS like workload. So, total workload, like total number of accelerations, distance covered, max speed, like all that kind of stuff. Yeah. So, some of this happens in practice, some of it happens in games. But we have all their baselines. And so, we kind of look to see, after they return to sport, did they get back to their pre-injury level? Not just self-reported, not just, I returned to the field, or I returned to practice, or I got back to competition, or yes, my performance was similar, but actually being able to measure it in a more objective fashion using these kind of GPS and IMU related data. Mm-hmm. The challenge with those, and you've kind of you hit at this in your question, which is there are so many things you can measure with these things. I mean, it's like you have an accelerometer, you have an IMU in there, like there are infinite number of measures that you can pull, and you have this time series continuous data. How do you reduce it down to something that matters? And really, in those scenarios, we lean on the athletic training and strength and conditioning staff to say, hey, these are what we think matter the most, or these are what we look at, or these are what we target. And so, then we have to operationalize and say like, okay, we're going to take some period of time before their injury and use that as a baseline. And we have to average it, because we just have these continuous data from, hours, weeks. And, so we take a snapshot of time. We take kind of the relevant days, like we know what days are in practice, what days are games. And we kind of, merge that together to kind of get a baseline assessment. And then effectively we do the same thing after they've returned to sport. We want to make sure we include the same number of practices, same number of games in the same window. We look at the same measures that they tell us, like, hey, these are what we think really matters. In our athletes, this is what we think is best linked to performance. And, our best athletes, or kind of the ones that are most successful on the field, these are the measures that they seem to kind of perform the best in, or whatever. And looked at that. So, again, I'm talking about this project a lot, but I think it was a cool snapshot into using real world kind of training room and on the field data and merging it with the bread and butter stuff for us, which is electronic health record and treatment and patient reported outcomes, and putting those together. It wasn't a big cohort, but it was a cool study and something that I think is going to be a model or kind of a test bed for doing future stuff like that. So that's one example of us partnering with, an outside, high performing, Power 4 athletics program to do a project. And we have plans to do similar types of studies with them, building on this first one. As you know, Major League Baseball, we work really closely with, and I would say, how do we, so going back to your question, I think it was kind of how do we design the research that we do in collaboration with them? Right. Is this driven by us? Is this driven by them? I would say all the above. Sometimes there are some studies that we do. And I think Glenn Fleissig would probably be better suited to talk in more detail. He just has a lot more history of doing research, partnering with MLB and MLB in particular, and other sports teams, mostly in baseball. But sometimes these will be clinically relevant research questions that we have, or that our clinical collaborators have, and we might work with MLB or seek MLB research funding or something to do a study. Sometimes it is them coming to us to say, hey, we are curious to see how this affects something that we can't measure. Or we want an independent group to evaluate these data or look at this idea, as opposed to having the individual teams or clubs.
Gotcha.
There is always, you know this a lot better than I do, but I think it'd be naive to say that there isn't some bit of competitive advantage, and teams, obviously every team is trying to beat the other teams. Of course. And so if they've kind of, found something that works or that they think is really important, I'm not saying that they purposely don't share it, but sometimes there is a really nice niche for, an independent research group that has the expertise to do some of these types of studies, to say, hey, we have no skin in the game here.
Right. It's a great point.
But this is what we found, whether it's related to athlete health or athlete performance. And I think that these have been published, but, for example, we did a study looking at normal baseball weight, and I wasn't directly involved in this, normal kind of standard weight baseball to a heavier ball. How does that, and a lighter ball, how do those affect biomechanics and throwing? And do either of those place athletes or pitchers at higher risk of injury, for example? That was one that was kind of collaboratively, I think, developed between us and MLB, or maybe specific people at MLB. I would say every study is a little different. Again, sometimes the more clinically focused ones, or stuff that is kind of a logical next step from some of the work that Glenn and John Slowick here have done. They might, submit proposals or try to get funding with MLB. Sometimes it's internal ideas that we serve as kind of the independent third party to maybe do a study. So hopefully that answers your question.
Yeah, absolutely. And it's a really interesting point you make. Again, I think all things we're talking about lead back to performance and winning. That's why people play. Interesting to hear you talk about, you guys being an independent group, and you may have a different mindset or different reason for doing certain things. It's just different clubs, pitching labs can turn one guy into someone who's getting option to AAA, and one guy who's dominating. It's just teams do things differently for different reasons, and they do research to help them win. So they can't share everything. So that makes total sense, and a great point by you. Well, Matt, one thing you mentioned a couple times that I'm interested to hear you talk about, AI is huge in every aspect of the workplace, whether it's clinical research or a pitching lab or someone who works as an accountant, anything. It's kind of not taking over, but impacting. And refining how people operate. How have you guys seen kind of technology in the past, even year or so, changing like the processes within your
Yeah.
clinical research?
Yeah. I mean, we're still trying to figure it out, honestly.
Yeah,
Like this stuff is advancing so quickly and it's
right.
becoming so ubiquitous that like, we'd be negligent to not try to figure out how to leverage it. At the
Sure.
same time, there's a lot that goes into that decision making. So yeah, I mean, I think we're really just exploring it. I think that there are going to be, I think that there's the potential for some really profound applications and insights into some of these types of data that we're talking about right now, like
Hmm.
wearable sports science kind of data, where there's just so biomechanics data too. I mean, there's just so much data. Like you're collecting continuous time series data throughout a movement, for example, or you're collecting continuous movement related data over hours and days. Um, One, how do we even make sense of that? I think it's really hard as researchers. Like, I mean,
Right.
even in best approaches to biomechanics data, like I have some 3D motion capture biomechanics training in my PhD. Like, you're still always reducing those data down to a manageable chunk that you can make sense of, which is like, okay, within this phase this phase of the movement that we think is relevant, whatever the movement is, like if it's walking, is it like foot contact, or it's like, stride, or it's swing phase, or whatever. If it's throwing, it's like, cocking or ball release or whatever. There are these moments or points of time in the movement that we know matter, or just historically have kind of been what's been evaluated. You're looking at measures at that point in time, or maybe within that range. But even within that range, like let's say, like as a really rudimentary example, like swing phase of the leg during walking or something,
Yeah.
you still have data through that whole, whatever it is, 2 seconds
Yeah.
at, 200, 300 frames per second. So like how much data you have even in those 2 seconds, how do you make sense of it?
Yeah.
And typically what we do is, we have certain measurements that we think matter, or we look at the maximum values, or we look at the minimum values, or something like that. But I think assessing big volumes of data like that, whether it's big outcomes cohorts, thousands of patients, or it's thousands of data points within a period of time, I think that is where we're going to really see in the coming years insights from AI that we don't even know we need to know yet.
Hmm.
Because no one's thought to look at it.
Yeah.
And I think stuff like that is where I'm really excited about seeing where it goes. I mean, yeah, of course, we're going to see like enhanced, like optimizing like efficiency with daily workflows of
Sure.
stuff. Like
Sure.
everybody's figuring that out right now.
Yeah.
On the clinical research side, I mean, we are starting to explore like how can we, our team spends a lot of time, for example, like collecting health record data. And a lot of it is just kind of like monotonous, like we're going through the notes and we're finding this data point and this data point, we're pulling this out. Or, is this something that like, maybe it's in like a point and click field and it's in some API that you could access. So like for stuff like that, one, can we, from a regulatory standpoint, patient privacy and adhering to those, which are very, very important, could we use AI tools to do something like that? How good would it be? Like we'd have to validate it and pilot test it and things like that. But we're getting to the point where some of these like, AI models can basically not do they just access data from some CSV file or something and analyze it really quickly, which is great. I mean, like there's tons of utility there. They're getting to the point where they can basically function like a human on a computer. I mean, they can like open the thing and they can log in with your credentials. So they can basically do everything that you would do, but like, 100 times the speed. It obviously is exciting to think about like how much more efficient or how much more, we could do more with less. And or this could give us some really clinically relevant and like important insights that could really positively affect our patients or our athletes.
Yeah.
But I mean, there's a lot of downsides too, like that. I don't even think we know what those are yet. But like, what effect is this? I don't know. I don't want to get too much on a soapbox related to it, but I think there's a lot that we don't know related to the limitations, and there are other things that we have to consider. Like we don't use it for any of our writing, and really we're very cautious to even use it with editing because one, and for good reason, you have to declare it, any paper that you publish. And there are real ethical concerns related to authorship and copyright and all this kind of stuff.
Right.
And so, yeah, I mean, I guess the very short answer is I don't know how we're going to use it or how it's going to affect what we do. But it is going to affect what we do.
Right.
That is certain.
Right.
We just don't know how yet.
Mm-hmm. No, that's a great point.
I think the potential for finding things that in large amounts of data is really exciting.
Yeah, I think the speed and efficiency aspect that you mentioned about with the conversation today, talking about the amount of data available, like I think that's going to be a huge help for everything you guys and a lot of people doing what you do make happen every day. It kind of leads me to our final question today. In wrapping up, I know we could talk about all of these topics for hours with the amount of knowledge you guys have over there, but kind of the overwhelm, like you talked about there, not overwhelm, that may be the wrong word, but the amount of stuff to take in and to understand within the research and data for the athletic trainer out there who might be just starting out in the minor leagues or working in their first athletic training room in a college setting. They want to get more comfortable reading, understanding, being part of the research process that you guys have so much expertise in. Where do you even start? Like there's so much information overload, AI tools.
For sure.
How do they begin to approach and apply research for their athletes to kind of improve their value as an athletic trainer?
Yeah, it's a great question. I mean, I think starting with it's still applicable right now, which is just kind of the evidence-based medicine model is a really great place to start, which is the research evidence is one piece of that kind of triad, but clinical experience and expertise and like the patient's values and specific circumstances are equal parts of evidence-based medicine. I think everyone thinks about evidence-based medicine or practice as like it's just the research articles and what the data show or whatever, which, that is what informs evidence-based medicine, but it has to be contextualized, related to the patient or athlete that's in front of you. And it has to fit into what you have the training to do and what your experience has shown too. So all three of those things have to come together. If the athlete is, if it's not a good fit, like they're different than the athlete cohort in the study, it might be apples and oranges. If it doesn't, based on your clinical experience, fit with what the context of their injury or treatment or recovery or whatever assessment is, then it doesn't matter. And so I think using that as kind of a level set is helpful first. And, that's something that's taught in really all clinically adjacent programs. I think looking second, if you're going to go into the evidence, like you want to know, like, hey, what does the research show related to this? Starting with sources of information from people that have already done the work for you. And so, when you think about the kind of cliche, like evidence pyramid, at the very top are like these, clinical practice guidelines or systematic reviews or whatever, those are studies or published recommendations from people that have already appraised the totality of the evidence related to some injury or treatment or topic. Starting there, as opposed to trying to read every individual study, there is a time and place. If there's some really important paradigm shifting study that found something that no one else has found, or had some really compelling data or something, or something that had thousands of patients, what I'm saying, like
Yeah.
there is a time and place to read an individual study. But I think if you can leverage work that's already been done by clinical researchers or clinicians with the existing evidence, that makes the process so much less overwhelming.
Right.
To get appraised on the evidence. And, usually those like clinical practice guidelines, for example, like NATA or AOSSM or APTA or other kind of larger like professional organizations and bodies will publish these types of things. And they're great resources. And usually they're published in a way to where they have like the main takeaways, the main recommendations, like right at the front.
Sure.
Of course, with big like syntheses like that, you're talking about all comers. Like these are big groups of athletes or big groups of patients. How similar are they to the athlete that's sitting right in front of you that you're making a decision about their treatment or care is what requires your clinical expertise and interpretation of the data. And so, like sometimes you just have to be like, hey, that's not relevant to what I need to do. Or maybe it is. Maybe it's a perfect fit, or that changes how you approach your treatment or care or assessment of an athlete. Sometimes it might not affect it at all. Or sometimes it's not working and you need to know when to make a change or, it's just using that clinical experience and like intuition as a part of that process.
Mm-hmm. That's a great answer. I think you kind of echo what a lot of our members have said about the early phase of their career, where it's like, hey, you got to understand there's textbooks, there's anatomy, there's research, but there's also a feel for the athlete, a feel that you can't be taught about, the relationships and communicating with your athlete. And like you said, understanding if what you've read and studied correlates and is related to what they need in that certain moment. And I think that's a huge piece of the humanizing part of what you all do, which is so important and cannot be replaced by a computer or robot or anything like that. So that's
for sure. I mean, you need that partnership between people who are seeing these athletes and patients, are training them, helping them, get to this high level performance, or treating them. Like we couldn't do what we do without those insights. Our work would not be relevant if we didn't have those types of partnerships and collaborations and insights.
Yeah, that's great insight from you there on how it kind of relates back to the athletic training profession. Well, Matt, I know, again, you have so much knowledge. We'd love to have you on again soon for another hour-long conversation about everything you guys do. But very grateful for your time, all you and the team at ASMI are doing to push kind of sports medicine research forward. And thanks so much for joining us today.
Yeah, thanks, Sam. Appreciate it. Had fun.